you, Chairman, and my dear friends. My talk today is on refractive surgery and peripheral retinal lesions. Just to have a brief summary, refractive surgeries can be based as cornea-based, lenticular-based, combined, where there is a Lasik being done, or there are corneal inlays being done, or phakic IOLs being done, or bioptics. We don't need to get into the basics of this because this is not what it entails. But this is a pre-LASIK correction evaluation where certain tests are generally carried out. This is a checklist which has to be done. And in that, you find that we feature in this place over here, where there is a detailed retinal evaluation and dilatation. Now, patients, for the counseling, the patient needs to be fully informed about the potential risks and benefits. The age should be above 18 years, the refractive status has to be stable for a year, and a retina check is mandatory. So the safety link, that what retinal specialists look for these things. They look for the status of the retinal attachment, the areas of degeneration, the health of the optic nerve head, the health of the macula, the main area of the retina, and the peripheral retina to rule out holes, breaks, tears, and any other areas of thinning like lattices, any vascular malformations, and the status of the gel for pre-existing degenerations and floaters. Now, what is the aim? The aim of a pre-LASIK retina checkup is to identify those conditions which require a pre-treatment. Holes, breaks, lattices need to get barrage laser 2 to 3 weeks prior to laser vision correction. Warning signals such as eye floaters, flashing lights mandates an urgent retina checkup. But majority of these conditions may be silent and can be only picked when you look for it. Hence, a preventive retinal check should always be done to have best results in a LASIK surgery. This is the relaxed smile. And the contraindications, again in this, which feature for us is the history of uveitis, personal or family history of retinal detachment, and diabetes mellitus, amongst all others. Now, the examination and imaging which is done is by indirect ophthalmoscopy, by a Goldmann 3-mirror contact lens with a slit lamp, or with a wide field laser ophthalmoscopy, the Optomap. Now, if you see you compare with the Goldmann 3-mirror, you find that there is a 91.73% specificity of retinal lesions, but for people who do not have recourse to that, you have to resort to your normal methods of indirect ophthalmoscopy and slit lamp examination with biomicroscopy. These are the kind of lesions that you would see and you pick up, and if you see these lesions, these have to be treated prior to the LASIK procedure. Now, what happens during a LASIK procedure? There are multiple mechanical stressors on the eye. There is a transient increase in the eye pressure during the suction phase. There's a sudden decompression of the eye when the suction is discontinued, and the acoustic waves during the laser ablation phase are also there. So you have to take these mechanical stresses into account because they have a potential to damage the retina and the vitreous, and these have to be thoroughly checked out. Now, what are the reasons? The suction ring increases the pressure and the IOP, and the anterior segment changes shape. So structures posterior to the suction ring are also compressed and decompressed in sequence. This trauma displaces the intraocular structures forward with the anterior hyaloid, which accelerates the vitreous detachment or causes traction at the vitreous base. When the suction is released, decompression produces a dynamic overshoot with equatorial expansion and shortening in the AP meridian, causing acute vitreoretinal traction at the vitreous and posterior pole. This is the possible mechanism for development of peripheral tears or macular injury. Now, the risk of RD because of alterations is about 0.08%, not much, but still present. PVD occurs in 0.1 patients and macular hemorrhages in 0.1% risk. So the treatment is that you do a laser or cryo. Cryo was done earlier, now it's only the laser mostly. It's done to lesions 2 weeks, at least 2 weeks prior to the LASIK. Periodic examination even post-LASIK, as tears can develop even post-LASIK. So the inferences an eye without pre-LASIK lesion can develop post-LASIK retinal lesions. A pre-LASIK evaluation with pre-LASIK retinal lesions is valuable in predicting the location of the post-LASIK retinal lesions. Pre-LASIK retinal examination and treatment alone may not be sufficient to prevent post-LASIK retinal lesions. Changes in the posterior vitreous status, such as sudden posterior vitreous detachment, is an important marker for vitreoretinal complications. Post-LASIK retinal evaluation is also important, as the pre-op examination does not guarantee the prevention of post-LASIK retinal lesions. So this is how it is. If the pre-lesions were here and you have treated it, the possibility of getting a post-LASIK lesion is somewhere close to it. And this happens because the laser tissue incarceration causes an acoustic pressure waves which propagate through the vitreous, and theoretically they can cause retinal breaks. The concave structure of the ocular interior wall will focus the acoustic energy, significantly increasing the local acoustic power density. So there are some studies which were done, and these concluded that with increased axial elongation, myopia may lead to retinal break formation. All these lesions of chorioretinal atrophy, Fox spot, lacquer cracks, pigmentary degeneration, and posterior staphyloma, and white without pressure need no treatment. The association of myopic LASIK with rhegmatogenous retinal detachment remains controversial, and the frequency of rhegmatogenous retinal detachment after LASIK is reported to be just 0.06 to 0.25%. The lattice degeneration is a risk factor for retinal breaks, may not progress into RRD by prophylactic laser photocoagulation before the refractive surgery, and post-LASIK RRD usually occurs in eyes with complex retinal breaks. Therefore, before the refractive surgery, a thorough retinal check is in order. So other data say the lattice degenerations occur in approximately 20% of myopes with retinal detachment, and surgeons recommend treatment for these lattice degenerations. So in conclusion, we can say LASIK appears to be safe to the retina with low incidence of retinal peripheral changes. And it is very important to inform the patients that LASIK only corrects the refractive aspect of myopia. The risk of complications related to the myopic eye will persist, and a long-term follow-up of these patients is important. Thank you.
Thank you, Karobi. Are there any questions?